Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. An estimated 10% of women of reproductive age may have endometriosis. We'll learn about the condition and why it can be difficult to diagnose from my guest, Dr. Katherine Frega. Dr. Frega is an assistant professor of obstetrics and gynecology at Upstate. Welcome to the Informed Patient, Dr. Frega.
Thank you for having me.
Let's please start with a description of what endometriosis is.
Yes. So endometriosis is a chronic inflammatory and estrogen-dependent disorder. It's characterized by the presence of endometrial-like tissue outside of the uterus.
So at what stage of life might endometriosis develop?
We typically see endometriosis develop primarily in women of reproductive age. There have been some cases where we see it before the age of menarche or before somebody gets their period. And we have also seen cases in menopause, but typically we see it occur throughout the reproductive age. So anytime people are experiencing menstrual cycles.
What signs and symptoms could it cause?
Endometriosis can cause painful periods, pain with urination, gastrointestinal distress during periods, pain with intercourse, chronic pelvic pain. We can see this be cyclical, so happening during periods, or non-cyclical, so happening anytime during the menstrual cycle. We also see it associated with infertility.
I was going to ask if it impacts a woman's fertility. Do you usually see that where a woman is having difficulty getting pregnant?
Endometriosis tissue causes a lot of inflammation, and the presence of it inside a fallopian tube could cause a fallopian tube blockage. It can impact normal ovulation, so impacting the ability for our sperm and an egg to meet. It also can alter the environment inside of the uterus, so it can make it very difficult for an embryo to implant normally. So yes, we do see patients who their only sign of endometriosis may be infertility.
What causes endometriosis?
So it's not completely understood, unfortunately, but we do know that it involves a complex interplay of hormones, so steroid hormones like estrogen and progesterone, the immune system, inflammation, environment, and genetics.
Genetics. So does it run in families?
Yes, so having a first degree relative, so if a patient has a mother or a sister who has a diagnosis of endometriosis, they have a 3 to 9-fold increased risk of developing endometriosis during their reproductive life cycle.
Beyond that, are there factors that increase a woman's chance of developing this?
Yes, so early menarche or an early age when you first start getting periods, a short menstrual cycle. So having a menstrual cycle be from the first day of your menses to the next first day of your menses be less than 26 days. Nulliparity, which means not having ever been pregnant before, and then having a low body mass index.
Is there anything that girls or women can do to prevent endometriosis? Because those sound like things that we don't have a lot of control over.
Because we know that inflammation plays a big role in endometriosis as well as estrogen, things that can decrease inflammation, like a regular exercise, so exercising 4 hours a week, having an anti-inflammatory diet can be helpful, avoiding alcohol and tobacco can all prevent endometriosis.
When you say an anti-inflammatory diet, can you tell me some of the things that would be on that diet and maybe some of the things that would not?
I tend to tell my patients to do a whole foods and mostly plant-based diet. So if they're going to be at a grocery store, sticking to the outside aisle of the grocery store. So lots of fruits and vegetables, trying to do dairy minimal. You can do meat, but mostly trying to do chicken, beans, but trying to avoid processed food. So trying to avoid all of the food that's in the middle of the grocery aisles.
The American College of Obstetrics and Gynecologists has new guidelines meant to improve evaluation and diagnostic care for adolescents and adults. Why have there been delays in diagnosis of endometriosis?
There are many barriers that the American College of Obstetrics and Gynecology has introduced. So patients can present with a variability of symptoms. Not every single patient that I see in a day might have the same symptoms. Some might only have painful periods. Some are only having pain with intercourse. There's also a very broad differential diagnosis for pelvic pain and abdominal pain. So there can be other factors because there's a lot of different organs within the abdomen, like your colorectal system, the urinary system, the kidneys, and there's also other infectious causes that can all lead to abdominal pain. There's also a lack of non-invasive method of diagnosis for endometriosis. So historically, endometriosis was only confirmed by surgery to see that there was endometriosis there. On the clinician level, inadequate training and recognition of all of the various different ways it can present can cause dismissal, can cause normalization of patients' pain, which leads to underdiagnosis and misdiagnosis. And unfortunately, these delays in diagnosis can prolong patients' physical sufferings. And on a societal level, the normalization of menstrual pain and then the stigma associated with menstruation can all contribute to this delay that we see in diagnosis.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Upstate gynecologist Katherine Frega about endometriosis. So today, how do you diagnose it? Do you use medical imaging?
I will diagnose endometriosis on a clinical history and physical exam. So I will take a very thorough history on a patient and suspect endometriosis in a patient who's telling me they have painful periods. In adolescents, if they've told me they have to miss school during their periods, or in adults, if they have to miss work during their periods, patients who are experiencing pain during intercourse, patients who are having infertility and have no other reasons to have infertility. On a physical exam, I can rule out infectious causes of pelvic pain. I can identify sometimes the adhesions or what we call frozen pelvis if the pelvic organs are not moving freely. Sometimes there can be an adnexal mass, like an endometrioma, which is endometriosis tissue inside of the ovary, and that we can pick up on a physical exam.
Once you have a suspicion that a patient has this, how is it treated? What do you recommend?
We can empirically treat patients. If I have a high suspicion based on my clinical history and physical exam, I can use imaging. I will use imaging if it's not clear to me. We can use transvaginal ultrasound as well as a pelvic MRI. Medical therapy for endometriosis typically involves ways to decrease estrogen in the body. And so we have a lot of different medications that are typically first line that are effective for decreasing estrogen and thus can relieve pain. Typically, the first line therapy is going to be a progestin therapy or combined estrogen progestin therapy. Many patients may have heard about birth control pills. So this would be a combined estrogen progestin therapy, a progestin intrauterine device. But then we do have other types of medications, and they all basically work to decrease circulating estrogen in the body.
Do the medicines do anything to the tissue that's already there?
It can prevent it from growing and spreading, but it's thought that if there is endometriosis tissue that's there and we're giving medication, it's not removing that tissue that's there, but it is preventing the endometriosis tissue from responding to the normal hormone cycles that happen during a menstrual cycle. So typically the endometrial lining inside of the uterus will grow in response to estrogen and then shed. The endometriosis tissue does this. It grows in response to estrogen, but then has nowhere to go and causes this inflammatory pain. So by preventing that cycle of hormones with medication, it helps decrease pain.
Does using these medications jeopardize or have any effect on fertility?
While a patient is undergoing medical therapy, essentially all of these treatments, fertility is eliminated because they inhibit ovulation. But to help a patient with infertility or becoming pregnant, we can use a combination of medical therapy and surgical therapy. But if I have a patient who medical therapy for endometriosis is working well, but they want to conceive, we do a trial of them coming off of the medication. And some patients with endometriosis might have no problems conceiving.
What are the risks if endometriosis goes untreated? Does it necessarily get worse?
Theoretically, if endometriosis is untreated, it can cause more invasive disease. So some patients might just have superficial lesions outside of the uterus. It can go deeply into the nerves. We have seen cases of endometriosis spread and actually be found in the thoracic cavity, which is your diaphragm where your lungs are.
Well, long term, does having endometriosis increase the risk for cancer or any other health conditions?
Unfortunately, endometriosis is associated with an increased risk of ovarian cancer. Compared to patients without endometriosis, patients with endometriosis may be more than 4 times likely to develop ovarian cancer. Untreated endometriosis or having endometriosis could lead to anxiety, depression, mental health problems if it's not being adequately treated, as well as GI symptoms like inflammatory bowel disease. I have seen patients with urologic conditions like interstitial cystitis, which is they can have pain with urination from endometriosis lesions. It's also typically seen in patients in disorders of inflammation like fibromyalgia and arthritis.
What advice do you have for someone? Because I know this can be a challenge to diagnose. What advice do you have for someone who wonders if this might describe what they've been going through? What do they need to tell their doctor?
I unfortunately am in the position where sometimes I see patients who I am the second or third doctor that they're seeing for these symptoms, and just giving a clear history of everything that's going on and telling the clinician how it's impacted their quality of life. When I have a patient in front of me validating their symptoms and also providing a diagnosis of, no, I don't think you just have painful periods. I think what you're telling me is that you probably have endometriosis. Validating their symptoms can create a lot of relief for these patients, and that they don't need to continue to suffer, and that we can start treatment for them.
Does it help for them to keep a diary or a calendar that lists the symptoms and what day it happened and how long it lasted for and that sort of thing?
Yeah, absolutely. Keeping a diary and coming with a diary of all of the symptoms that they're having throughout the different parts of their cycle can be very helpful. There's also a lot of apps that are available that can track the menstrual cycle. And it also has the ability to tell the app what symptoms that you're having at different parts of the cycle. That can be incredibly helpful to have a patient pull up their app during a visit and share with me when they're having the symptoms that they're experiencing.
Well, Dr. Frega, thank you so much for making time for this interview.
Absolutely. Thank you again for having me.
My guest has been Dr. Katherine Frega, an assistant professor of obstetrics and gynecology at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.